Okay, thank you all. And thank you again for coming. I want to also thank Roger Hertog for supporting this program, as he has this year and last year, and next year. This is a research program on the history and future of world problems. And of course, this talk in particular, I think is one that really brings it home. When we look at the problem of tuberculosis in New York City, how it came to be an epidemic, but also one, of course, that we can see in a more global context, and I'm sure that's going to be part of the discussion as well. And who better than James Colgrove to tell us about it? He is someone who I really think for someone of his age has been putting a lot of the rest of us to shame, in terms of his research and his publications. He's the author or editor now of 3 books, and the latest is Epidemic City. I would hold it up if I'd remembered to bring it to the podium with me. It was just published a couple weeks ago. Epidemic City is there it is. He's also selling it out of the back of his car. We're going to pull it up after the talk, but just kidding. So it's a history of public health in New York City, and as we've just been discussing now, James was kind enough to talk with our students, talk with Kavita Sivaramakrishnan students. He's been talking now for 3 hours already, I should tell you. New York City has really been at the forefront in many ways in dealing with problems of public health. It's been a model for other jurisdictions around the United States and for other countries around the world. And so here again, even if we're bringing it home tonight and looking at tuberculosis in New York, we're doing so in a global context, and I know that we're going to learn a lot from it. So let me just finish by also thanking the others who made this possible. I'm thinking of the Center for the History and Ethics of Public Health at Columbia's Mailman School. Thank you, David. And I want to thank, too, the Communications Department of the Mailman School that provided the refreshments tonight. So with no further ado, let me turn things over to Professor James Colgrove of the Mailman School. Thank you.
Thank you, Matt, for that very nice introduction, and thank you all for coming tonight. Tuberculosis is a disease of unparalleled global significance. About 1/3 of the world's people are infected with TB. An estimated 1.7 million people died from the disease in 2009. TB is the classic disease of deprivation and poverty. It spreads where people lack basic material needs, adequate and stable housing, employment, and access to health care. In my talk this evening, I'm going to present a TB success story that followed a series of notorious public health failures. In the 1980s and 1990s, New York City experienced a deadly resurgence of TB. The strategy that brought the disease under control proved to be an influential model for policy at the World Health Organization and is still cited today as an example from which public health professionals globally can learn. Exactly what lessons are to be drawn from these events may not be straightforward, however. There's a long-standing debate, as I think all of you know, within public health about whether the most effective and durable way to reduce disease is to address the root causes of disease, that is, the underlying social and economic circumstances of people's lives, or whether it's to use targeted interventions like antibiotics, vaccines, and other technical solutions that leave broader social conditions untouched. Which approach is more effective? Which approach is more ethical? The story of TB control in New York City exemplifies the tensions between these two alternative approaches. Oops, why did I do that? Come back. All right. Leo Maker, 38 years old, homeless, drug-addicted, and sick with tuberculosis, seemed to personify, at least in the minds of the editors of the New York Post, the social disorder engulfing New York City when the Post ran a full-page photo of him on its cover next to the headline, "One Man's Trail of TB." This was the first in a series of articles on the disease in the fall of 1990, a time when the city was reeling under the effects of severe budgetary shortfalls, a skyrocketing murder rate, the seemingly uncontrollable spread of AIDS, and the effects of the epidemic of crack cocaine. TB resurged among the city's poorest and most troubled residents. The rate of disease among welfare recipients who abused alcohol or drugs was 70 times as high as the rate for the U.S. population overall. The problem was most severe in Harlem, a neighborhood that had long symbolized and epitomized deprivation in the midst of affluence. In 1990, New York City held 3% of the country's population, but accounted for 15% of its TB cases. This problem had been years in the making. By the time this story ran, rates of TB in the city had been rising for more than a decade, and a looming crisis had been predicted by numerous advisory panels, community groups, and experts inside and outside of government. So how did New York City end up in this dire situation? Why had TB, a disease treatable with antibiotics, resurged, and why had rates continued to rise for more than a dozen years before an effective control program was put in place? Answering those questions will help to make clearer the significance of what New York City did and didn't do to remedy the problem. So to understand the roots of the problem, we have to go back several decades and look at the evolving medical management of TB. So first, a bit of medical background that may be familiar to you. TB is an airborne disease caused by a bacillus that most commonly attacks the lungs, although it can attack other organs as well. In most patients, the infection remains latent and asymptomatic. Patients have a roughly 10% lifetime risk of progressing to active symptomatic illness. That risk is increased when patients' immune systems are weakened. Symptoms include severe cough, fever, weight loss, and fatigue. When patients are not symptomatic, they are not infectious. But when they become symptomatic, they can pass the disease on to others through airborne droplets, as in coughing or sneezing. So later on in my talk, when I refer to cases of TB, I'm going to be talking about active symptomatic cases. Before the mid-20th century, there was no effective treatment for TB, and the standard therapy consisted of several months of bed rest, often in a sanitarium like the one shown here. In the post-World War II era, however, the development of several new antibiotics transformed the medical management of TB. These new drugs could cure TB, and they allowed patients to be treated on an ambulatory basis. New York City established a network of outpatient clinics dispensing oral antibiotics. The shift from an inpatient to an outpatient model of care brought a new set of challenges, however. A full course of therapy typically took 6 to 9 months, but the acute symptoms of the disease generally subsided after a few weeks, at which point many patients, no longer feeling ill, stopped taking their medication. And the failure to complete therapy led to the development of resistant strains of the bacillus. And as we'll see later on, the development of drug resistance would play a critical role in subsequent events. By the time antibiotics were introduced, the case rate and the death rate for TB had been declining for many decades for reasons that are somewhat in dispute among historical demographers and others who study long-term trends in morbidity and mortality. One thing that was almost certainly responsible for the decline was improvements in housing. So, for example, things like stricter building codes that limited the amount of overcrowding in tenements. But the introduction of antibiotics clearly had an impact on further driving down the case rate and the death rate. So this chart is a little busy, so let me walk you through it. There's two sets of lines here. Do we have a pointer? Okay. So these are the TB case rates, and this is the TB death rate from 1930 through the end of the 1960s. And the three lines, the top line in each case is New York City. This is New York State, including New York City, and this is New York State outside of New York City. And two things to draw your attention to. First of all, the most obvious thing, if I can, where's my little arrow? There it is, hello, is the difference between the case rate and the death rate in New York City compared to the rest of the state, how much higher it is. So New York City has a much higher rate. And then notice that there's an overall downward trend that is accelerated by antibiotics. So you can see that the trend, it's a little bumpy, it's a little up and down, but was steadily declining. And then around the early 1950s, with the widespread deployment of antibiotics, the rates of both decline even further. The drop in the death rate is quite dramatic. The decline in the case rate is a little less, but they both, the decline is accelerated by the introduction of antibiotics. So this decline coincided, coincided with another historical trend, which was the increasing concentration of the disease among the poor. There was widespread agreement during this period, the 1960s, that social problems were at the root of tuberculosis, and so the best way to fight the disease was to address these underlying issues. In 1967, a report by the City Health Department's Bureau of Tuberculosis made the following comment. They said, quote, "Probably the most important preventive measure in tuberculosis is improvement of the socioeconomic conditions of the population most at risk. This requires improved housing, education and job opportunities, and stabilization of the family." The report went on, "Such activities are not within the framework of the Bureau of Tuberculosis, but increasingly we should concern ourselves with these social aspects of health maintenance." Well, in fact, the health department did not end up concerning itself with these social aspects of health maintenance. On the contrary, what happened next was something that has often happened in the history of public health. Success bred complacency, and over the next decade, tuberculosis was increasingly ignored. Concern about TB dwindled as medical and public health professionals grew convinced that infectious diseases no longer represented a significant threat in the U.S. If you're in the Hertog Institute classes this summer, you've heard this in your classes, and you know from your other lectures in this series that there was a widespread perception during the 60s and 70s that we didn't need to be worried about contagious diseases anymore. We had conquered contagions. A couple weeks ago, Matt quoted an expert from the early 70s saying, "Whatever the future of infectious disease holds, we can be sure it will be dull." Right, and that belief certainly extended to the belief that we just didn't need to be worried about TB anymore. At the same time, there was a waning of the Great Society liberal belief in activist government, particularly the belief that the government should try to ameliorate the problems of the inner city poor. During the 1960s and the federal war on poverty, ambitious social programs had flourished, and annual federal spending on health climbed steadily. But with the election of Richard Nixon in 1968, the idea of activist government, the idea of activist government went into retreat, particularly in Nixon's second term. Particularly in Nixon's second term, when his administration made deep cuts to spending on health and social welfare. It was within this context that New York City's TB control programs were almost completely dismantled in the 1970s. The majority of the city's TB control programs were paid for with federal and state funding. And during the 1970s, virtually all of that funding was withdrawn, so that by 1980, local tax revenues supported virtually all of the city's TB control efforts. This would have put an enormous strain on local fiscal resources under the best of circumstances, and as many of you know, the 1970s were certainly not the best of circumstances for New York City. In 1974, New York City collapsed into fiscal insolvency. For years, the city had been spending more money than it took in and borrowing to cover the difference, and this untenable strategy came to an end when lenders, the big banks, decided that the city was no longer a good credit risk and refused to continue underwriting the city's debt. The city was forced to make drastic reductions in municipal services, police, fire, sanitation, and higher education. Does anyone remember who was the mayor of New York City in 1975? Very good. You guys are good. Abe Beame. People don't usually remember poor Abe Beame. He was a rather colorless character. And who was the president? Gerald Ford, right. So in the fall of 1975, Abe Beame went to Washington to plead for a federal bailout from President Ford. President Ford turned him down. prompting one of the Daily News's most famous tabloid headlines, Abe is Abe Beam, Carey is New York State Governor Hugh Carey. The health department, which was responsible for coordinating TB control in the city, was one of the hardest hit, by some measures the hardest hit, of any city agency during the city's fiscal crisis. Between 1974 and 1977, the health department lost a quarter of its staff, going from around 6,000 employees to around 4,500. There were major cuts in virtually all program areas, including TB control. 5 of the department's 15 outpatient TB clinics were closed, and the Bureau of TB Control lost 83 employees, more than half of its staff, including, critically, almost all of the field investigators whose job it was to visit patients in the community, to monitor their progress with their medication, and to encourage them to continue taking their medication. The outreach staff, following more than 2,000 ambulatory patients in the city, fell from 20 to 2. And you can probably do the math on that yourself, but yes, that does come out to a caseload of about 1,000 patients per caseworker. There remained in the city a small community of TB experts who were not convinced that infectious disease was conquered, and for them the effects of these cuts was not difficult to predict. When the state halved its financial contribution in 1978 and signaled that it would soon end its support completely, the health department's director of TB control prepared a report titled Tuberculosis Control: An Impending Crisis. And the report stated bluntly, tuberculosis is not under control in New York City. The report noted that the TB rate in the city was around twice the national average, and that in the neighborhoods of Harlem, the Lower East Side, and Bedford-Stuyvesant, it was 6 times the national average. Commenting on the imminent withdrawal of funding, the report predicted, tuberculosis cases will go unreported and unsupervised, tuberculosis contacts will go undetected, the untreated cases will walk in the streets of New York, the unexamined contacts will break down and feed the city's TB reservoir. And as it happened, all of these predictions turned out to be exactly true. The following year, the TB case rate rose for the first time in more than 2 decades. The rise in cases prompted a small infusion of resources. In 1980, using a combination of city and federal money, the health department hired 21 new outreach workers to monitor patients. The following year, however, several staff members whose salaries were paid for by the CDC had to be let go because of cuts to public health spending in the Reagan administration's first budget. Over the next 4 years, the city's TB control infrastructure was the subject of 3 detailed and highly critical reports which documented a litany of clinical and administrative problems that resulted in the systematic failure of patients to receive adequate care. Because infectious disease medicine was seen as a kind of clinical backwater, the city had a very difficult time recruiting high-caliber physicians to work in its TB clinics. As a result, patients were often received substandard care, for example, being placed on drug regimens to which they had documented resistance. Patients drifted away from care because there were insufficient staff and resources to follow them. The inadequate clinical management of TB was evident in patient outcomes. The CDC recommended that in any jurisdiction, 90% of patients should convert to non-infectious status within 6 months of beginning treatment. In New York City, only about 50% of patients did. The dismantling of the TB control infrastructure laid the groundwork for the resurgence of TB in New York City, and at this point, 2 additional factors combined to increase rates of illness in the city. The first factor was the increase in the city of poverty and homelessness. In the 1970s, some 250,000 blue-collar jobs disappeared from New York City, the result partly of broad-based changes in the regional and national economy. The percentage of city residents living in poverty rose from 1/5 to 1/4. The city lost much of its low-income housing stock in the 1970s, and beginning in 1981, the Reagan administration gutted federal housing assistance to the poor. All of these factors combined to create a large population of homeless and unstably housed men, women, and children. Between 1960 and 1980, the average number of homeless families in the city's temporary shelters was around 600 per month. By the mid-1980s, that number had risen to around 5,000 per month. TB had long been recognized as a particular problem of the homeless. The transient, disordered existence of people living on the street made taking pills and keeping medical appointments difficult, and the dormitory-style shelters that became commonplace in the 1980s, such as the infamous Fort Washington Armory shelter, directly across the street from the Columbia School of Public Health, was the ideal setting for the spread of airborne contagions, really the spread of contagions of all sorts, but particularly airborne contagions. As New York City began to warehouse thousands of people in these environments, the number of TB cases diagnosed among shelter residents climbed steadily. The problem was particularly severe among homeless alcoholics, whose weakened immune systems made them vulnerable to reactivation of latent infection. The second factor that proved to be critical in the resurgence of TB was the appearance in the city of AIDS. This is the first article from the New York Times on the mysterious cases of immune suppression that had begun to appear in the city. Although initial attention focused on cases among homosexual men, it soon became apparent that the disease was also spreading rapidly among injection drug users and their sexual partners. And within a few years, the majority of new AIDS cases in the city were being diagnosed in drug users, and more than half the city's AIDS cases were Black or Hispanic. A 1985 report by a non-governmental health organization noted that the groups most affected by AIDS and TB were the same: Black and Hispanic males aged 25 to 44, and that a diagnosis of one disease in this group closely preceded or followed another. The report observed, quote, "Traditionally, compromised immunity among those infected with TB has resulted in disease. It is plausible to suggest that epidemic immune deficiency may be associated with increased TB incidence." Several studies published over the next few years verified this speculation. People with AIDS were far more likely to progress to active TB than those who were not immune compromised. As Karen Brudney, a physician who treated homeless patients at Harlem Hospital, put it in a subsequent article, she said, quote, "The advent of HIV in the 1980s poured oil on the smoldering coals of TB among the homeless." This chart shows the incidence of TB in the city over about 30 years, from 1978 to a couple of years ago. And you can see in this chart the effects of the three factors that I've just outlined: the dismantling of TB control infrastructure, poverty and homelessness, and epidemic immune deficiency. So recall that, let me get my pointer here. Recall that the trend line had been going down for many decades in a steady downward trend. In 1978, cases ticked back up for the first time in decades as a result of the dismantling of the city's TB control programs. Cases continue at a somewhat elevated rate for several years, and then in the mid-1980s, beginning around 85 and 86, you see the combined and synergistic effects of homelessness, poverty, and HIV. And then, excuse me, and then rates continue to rise over the rest of the decade. By 1992, when cases peaked in New York City, the city recorded more than 3,500 cases of the disease, more than triple the number of cases in 1978, when rates had begun to creep back up. This map shows the geographic distribution of New York City's TB cases in 1992, the year that cases peaked. On this map, each dot represents a case of TB, and the map is divided into census block groups that are shaded according to the level of poverty, and a darker level of shading indicates a higher level of poverty. And you can see a very clear patterning here of high concentration of dots in the darker areas of the map with higher poverty. So, get my pointer. So we are here in the little island of Columbia, surrounded by Harlem, a very, very traditionally high poverty area with the city's highest clustering of TB cases. And you see a similar patterning here in the South Bronx, on the Lower East Side. This is, of course, before Whole Foods came to the Lower East Side, and it became a gentrified playground for the wealthy. This is Bedford-Stuyvesant, and of course, conversely, you see the opposite pattern in the very lightly shaded areas, very few dots. So the Upper East Side and Midtown East, very few dots. The relatively affluent suburbs of Queens, Bayside and Forest Hills, very few dots. So very clear correlation between the TB case rate and poverty. As rates were rising in the late 1980s, public pressure built on the city to do something. City council members, state assembly members, and other politicians began to put pressure on Mayor Ed Koch, who in turn pressured various city agencies to address the problem, including the health department, the city's public hospitals, and the Human Resources Administration, which ran the city's homeless shelters. But the city's response remained incoherent and inadequate. Public health was chronically underfunded during these years, and many public health leaders were lulled into thinking that because TB was, at least in theory, treatable with antibiotics, it did not pose a severe threat. As has often been the case in the history of public health, it would take an urgent crisis to spur action. And that urgent crisis arrived in the form of outbreaks of TB resistant to multiple drugs, so-called MDR-TB, or multi-drug resistant tuberculosis. Cases of MDR-TB began to strike in institutional settings in 1990. A dozen inmates and one guard died of MDR-TB in jails in Queens and upstate in Syracuse. Around the same time, local hospitals began reporting outbreaks of MDR-TB among their patients. So recall that I mentioned earlier that the potential problem of drug resistance had been recognized as early as the 1950s, but drug-resistant cases had never represented a significant number of cases in the U.S. And in fact, by the mid-1980s, the CDC had become so convinced that drug resistance was not a problem in the U.S. that it had stopped conducting systematic surveillance of drug-resistant cases. So when these new cases began to occur, it was impossible to know if they were anomalies or if they represented a wider epidemic. That question was answered by a young physician epidemiologist with the CDC who was on assignment in New York City with the health department named Tom Frieden, who, of course, as many of you know, is now the head of the CDC. With 3 assistants, Frieden trekked to 72 hospitals around the city, collecting sputum samples from patients who had been diagnosed with TB in the spring of 1991, and he did drug susceptibility testing on those. And what he found was even worse than what many people had feared. 20% of patients had strains resistant to both isoniazid and rifampicin, the 2 first-line drugs. A third of patients were infected with strains of TB resistant to at least one of the standard drugs. Although the strongest predictor of having a drug-resistant strain was a history of having received prior treatment, as you might expect, the majority of patients with drug-resistant strains were initially infected with the drug-resistant strains. Officials at the CDC were so alarmed by the high rates that Frieden and his team uncovered that they did a nationwide survey that found that New York City accounted for more than half the cases of drug-resistant TB in the country. The public health implications of these findings were grave. The case fatality rate for TB resistant to 2 or more drugs is 40 to 60%. Treating drug-resistant strains involves an even more complicated medication regimen that can take as long as 2 years to complete. It was the emergence of widespread drug resistance and the danger that these new strains posed in occupational settings to healthcare workers and other hospital employees, to police officers, child welfare workers, prison guards, and others, that was the critical factor in bringing public attention to the problem. The mayor at this time, at the time that drug-resistant strains began to appear in the city, was David Dinkins, and as his health commissioner, Dinkins appointed Margaret Hamburg, who spoke in this lecture a couple of weeks ago. She, of course, is now the head of the Food and Drug Administration. When Dinkins appointed her, she was only 36 years old. She was the youngest health commissioner in the city's history. Dinkins appointed her right around the time that the problem of drug resistance was becoming apparent, and as soon as she assumed the job, Hamburg moved swiftly against tuberculosis. One of the first things she did was to appoint Tom Frieden, the director of the Bureau of TB Control. One of the other first things she did was to get more money for the problem. It was clear that the magnitude of the problem outstripped the local resources that New York City could marshal, and that federal financial support would be necessary. Congress had authorized the CDC to spend $36 million nationwide to fight TB, but only $15 million of that had actually been appropriated. Hamburg wrote to members of the state's congressional delegation. She drafted a letter for Mayor Dinkins to send to the U.S. Secretary of Health and Human Services. A House subcommittee held hearings on TB in late 1991, and in the wake of that hearing, Congress made an emergency appropriation of about $100 million to the CDC's budget for TB control. Of that amount, New York City received $40 million. Because non-adherence to medication had played such an important role in the emergence and spread of drug-resistant strains, it was clear that the city was going to have to adopt much more aggressive means of increasing patients' treatment completion rates, that is, the percentage of patients who completed their full course of TB medication. So I'd like to see a show of hands here. Please raise your hand if you have ever been prescribed a course of antibiotics for any reason. Okay, keep your hands up, put them up high. Please keep your hand up if you always have taken every single pill you were prescribed, all the way down to the very last pill. Oh, come on, you guys aren't telling the truth. Okay, thank you. This is interesting. You know, I ask this question every year to my public health students, and they also always keep their hands up. And I never know if this is because public health students aren't a representative sample or if there's some kind of social desirability bias going on. So if you put your hand down, please go stand in the corner. Now, if you put your hand down, don't feel bad because you're actually in very good company. There's a very big literature on non-compliance and non-compliance with medication orders, and that literature is very clear and consistent. People are not good at taking their medication. For patients young and old, male and female, well-to-do and indigent in the developing world and in economically advanced nations, non-compliance with medication orders appears to be a universal tendency. One expert on compliance wrote, quote, "The individual who uses new drugs on a routine basis without help and encouragement from others is probably the abnormal one." So you all are abnormal. TB presents a much more difficult problem than most diseases. It's treated with multiple pills that can have very unpleasant gastrointestinal side effects. As I mentioned earlier, symptoms abate soon after treatment has begun, but several more months of medication are necessary before the patient is cured. Directly observed therapy, or DOT, in which outreach workers monitor the patients, watching them as they swallow the pills, was an attempt to address this problem. DOT had first been used by public health officials in Hong Kong and Madras, India in the 1950s, and had been very successful there at achieving high treatment completion rates. In the US, however, only a few local and state health officials had adopted DOT because the costs were seen as unjustified given that rates of TB were on the decline, and after all, we didn't need to be worried about infectious diseases anymore. DOT raised several ethical and pragmatic concerns which Peggy Hamburg and Tom Frieden had to confront as they considered implementing it in New York City. Who should be placed on DOT? Homeless patients and injection drug users? Well, these groups were more likely than others to be non-compliant, but the problem was by no means limited to these groups. One study found that about half of all patients stopped taking their medication for at least 2 months. Should DOT therefore be offered to every patient as a default? Should it be required of every patient? Was requiring patients to be watched while they swallow their pills a coercive and paternalistic intrusion on patient privacy? Would putting all patients on observation waste scarce resources on patients who might otherwise take their pills without assistance? Would DOT send a stigmatizing message that health officials believed patients couldn't be trusted? Or would universal DOT reduce stigma by normalizing the process of taking medication under observation? Hamburg and Frieden ultimately decided that the city would implement a policy of universal DOT. Patients, in theory, could opt out of the program, but the health department presented it to patients newly on therapy as, this is what we do. That was the line. This is just the way we do it. So probably many patients had the impression that they had no choice but to take their medication under observation. And if a patient opted out of DOT, but then subsequently was found not to be taking their medication, he or she could then be ordered to take the pills under mandatory DOT. In early 1992, there were just a handful of patients receiving DOT under a small CDC-funded pilot program. And as you can see from this chart, over the next 3 years, the number of patients on DOT climbed steadily. So that by the end of 1995, approximately 80% of all TB patients in the city were receiving DOT. And not shown on this chart, about 90% of patients who had multi-drug resistant TB were receiving DOT. A huge core of outreach workers was hired to implement this program. A big chunk of the $40 million emergency appropriation that the city received went towards hiring several hundred outreach workers to administer DOT. There were two primary forms of DOT. One was clinic-based, in which patients came daily or twice weekly to receive their medication. The other consisted of community-based appointments at sites that the patients themselves chose. Homes and workplaces were the most common venues for receiving DOT, but the outreach workers went to every imaginable location. They went to welfare hotels, to crack dens, to street corners, to train stations, to homeless encampments, anywhere the patients were. In some cases, the sites for DOT appointments were chosen because the patients didn't want their families, friends, or coworkers to know they were being treated for TB, but in many cases it was because the patient had no stable residence or employment. If DOT raised concerns about its potentially coercive aspects, another key component of the city's TB control program was even more sensitive and potentially controversial: involuntary confinement of non-compliant patients. Detention had a longer history than DOT, and an even more checkered one, having often been used against the disadvantaged of society. When antibiotic therapies had been introduced in the 1950s, more than 30 states used involuntary hospitalization for patients who were deemed unlikely to complete treatment. And as you can imagine, that judgment was often influenced by social prejudices, with alcoholics and the homeless being much more likely to be subject to detention. In New York City, the health department had used detention on a very limited basis for persistently non-adherent patients in the 1970s and the 1980s. This is an example, I don't know how well you can read this, of a TB detention order from the city health department to a treating physician, and I blacked out the name of the patient. Can you all read that in the back? So at the top it says, "Please be advised that because this patient has infectious communicable pulmonary tuberculosis and because she has demonstrated a lack of concern for her own well-being and a severe lack of cooperation regarding medical treatment, an order to detain has been issued." And down here in this paragraph, you can see the specifics of the detention. A 24-hour guard should be placed on the patient. Any attempt to escape from the hospital should be thwarted. It is advised that all personal belongings, keys, clothing be taken away to expedite treatment. No passes are to be issued, etc. And I should note at this time that the city did not have a locked TB ward dedicated to the care of TB patients under detention. Each time one of these orders was issued, the treating hospital had to arrange for a guard to be stationed outside that patient's door. And this is the order that was given to the patient herself. A detention order has been placed on you. This means you are not allowed to leave the hospital, etc. Now, note here on the last line, it says, "You may appeal to the Board of Health pursuant to Section 5.21 of the Health Code." As New York City contemplated what was likely to be an expansion of the use of detention, one of the things that had to be done was that the Health Code had to be amended. So why was this necessary? Well, the Health Code granted very broad discretion to the Health Commissioner, and it provided no explicit guarantee of due process for the detainee. And this was a problem because over the previous 2 decades, courts around the country had issued an array of influential decisions expanding protections for individuals against government coercion. Many of these were in the realm of criminal justice, famous cases like the case that required now the Miranda ruling, Gideon v. Wainwright, which required defendants for indigent criminal defendants. But many of these cases came out of the realm of medicine. So, for example, commitment statutes for people with mental illness, drug addiction, and alcoholism had to ensure that the people detained were able to contest their confinement before a judge. In 1980, the West Virginia Supreme Court struck down a statute for the detention of TB patients because the patients were being held without written notice and right to counsel. Although the constitutionality of New York City's TB provisions had never been challenged, it was clear that they were not going to stand up to court scrutiny. So in April of 1983, the Board of Health approved a package of amendments to the health code. Under these amendments, patients could be ordered to take their medication under direct observation, and if patients failed to comply, they could be detained involuntarily in an inpatient facility, not just until they were non-infectious, which could happen in a few weeks, but until they were completely cured, which in the case of MDR-TB could take up to 24 months. Under the new provisions of the health code, the health department had to inform the patient of the right to be represented by an attorney and to provide an attorney if the patient asked for one. If the patient requested release, the commissioner had to respond before the court within 72 hours. The city established 2 locked TB wards dedicated to the care of TB patients, a 25-bed ward in Goldwater Memorial Hospital on Roosevelt Island and a 21-bed ward at Bellevue on the east side, both of which opened in 1993. The Goldwater ward has since been closed, but the city still operates a locked TB ward at Bellevue Hospital. In the mid-1980s, fewer than a dozen patients had been detained each year for persistent noncompliance. In the 2 years following the revisions to the health code, 139 patients were detained. For those with drug-susceptible TB, the median stay was 21 weeks. For those with multi-drug resistant TB, the median stay was just under a year. The percentage of patients detained overall was quite small. It was only about 2% of all patients. But everyone associated with the TB control program agreed that a credible threat of detention was critical to the success of DOT. That is, patients were told, if you don't cooperate with your DOT outreach worker, you will be sent to a locked hospital facility. As the city was formulating its plan for compulsory DOT and detention, many civil liberties advocates argued that these measures were a misguided diversion from the real issue at hand, addressing the social and economic problems that lay at the root of TB. George Annis, a public health legal scholar and ethicist writing in the New England Journal of Medicine around the time that New York City's control program was going into effect, voiced a widespread view when he said that DOT and detention, quote, concentrate on the victims of social neglect rather than on the neglect itself. Annis went on, this focus is understandable since poverty is a much more difficult problem to address than the treatment of tuberculosis. But the history of the disease shows that success in controlling tuberculosis depends much more on the general standard of living than on specific medical or legal interventions. So whether or not this is true is an open question. This is the graph that I showed you earlier, and you can see how beginning in 1992, when the city's control program of DOT and detention went into effect, how quickly the cases came down. By the end of 1993, some 18 months after the strengthened program began to be put into place, the number of TB cases in the city had declined by 15% from the previous year. The following year, new cases dropped even further for a 2-year decline of more than 20%. The portion of patients completing their treatment rose from about half to about 90%, and the percentage of cases that were drug-resistant declined from 1/3 to 1/4. And this decline, as you can see, has continued ever since. And just a few months ago, the City Health Department released a news release saying that cases of TB in the city were at an all-time low. So this is the press conference in the spring of 1994 where the Health Department announced the second sharp drop in TB cases. That's Tom Frieden at the lectern, flanked by Peggy Hamburg and Mayor Rudy Giuliani. The following year, Tom Frieden went to India to work under the auspices of the World Health Organization, where he marshaled a massive effort using directly observed therapy and achieved similarly remarkable improvements in the detection and cure of patients. Also, the following year, in 1995, the World Health Organization announced that its new strategy for the control of TB would have directly observed therapy as its centerpiece. New York City's approach had targeted one of the most important factors contributing to the unchecked spread of TB. It had strengthened the inadequate clinical management of TB and increased treatment completion rates, the percentage of patients completing their treatment, through universal DOT. And I should note also that one of the other important things that the city did was that the health department undertook a major hiring of new, better-trained physicians to work in the city's TB clinics, and they did a major staff training and education effort throughout the city's hospitals to ensure that the quality of clinical care improved. What the city's control program did not do was what the health department had urged it to do back in the 1960s in that memo that I quoted to you earlier. It did not address the underlying social factors that fueled the epidemic. The program of directly observed therapy worked within structures of poverty and deprivation: welfare hotels, homeless encampments, crack dens, neighborhoods devastated by the federal war on drugs, rather than attempting to reform them. Homelessness did not decrease in New York City in the 1990s. Punitive narcotics laws that marginalized injection drug users and devastated poor communities were not repealed. Drug treatment was not expanded. New York City's economy boomed in the 1990s, but these gains did not accrue equally to all city residents. Instead, economic polarization reached unprecedented levels over the 1990s. Those involved with the city's TB program were not unaware of the need to address the underlying social pathologies that fostered the spread of TB, but the urgency of the situation that confronted the city in 1991, with spiraling rates of disease and the emergence of widespread drug resistance, tested the health department's commitment to those ideals. Tom Frieden, defending the use of detention in a presentation to the Board of Health, made the following comment. He did not dispute that the people most likely to be targets of coercive measures were already disadvantaged in many other ways, but he said, quote, "Although society is in part responsible for this situation, this doesn't mean no action should be taken. To continue to allow these individuals to infect others compounds social injustice with deplorable inaction." Similarly, Margaret Hamburg, commenting on the tension between the need to attack the root causes of disease and the imperative to act quickly to prevent sickness and death, put the matter this way. She said, quote, "We cannot afford to hold off on TB control efforts and wait until a damaged society is repaired." For public health professionals committed to ideals of social justice, this dilemma continues to frame TB control globally. And this is particularly true where problems of drug resistance raise the level of urgency. In 2006, health officials in South Africa reported the emergence of so-called XDR-TB, or extensively drug-resistant tuberculosis, which is resistant not only to the 2 first-line drugs, but also to at least 3 of the 6 classes of second-line drugs. Once again, New York City provided a potential model for how the disease might be controlled. Jerome Singh and his colleagues, raising the possibility that detention might be used for some patients, wrote, quote, "Emulation of New York's approach in controlling its TB outbreak could empower health officials in South Africa and elsewhere to act decisively in tackling emerging XDR-TB and MDR-TB epidemics." The control of drug-resistant TB in New York City in the 1990s was undoubtedly a triumph, one that has since been widely cited in journals of medicine and public health as a case study of what can be accomplished when the basic tools of public health are applied with sufficient funding, commitment, and skill. That it was an essentially technocratic solution is not necessarily inconsistent with the commitment to social change. Working in the context of profound injustice, Peggy Hamburg, Tom Frieden, and their colleagues saw the health department's TB control effort as a form of justice. to the extent that it relieved the disproportionate burdens that illness places on the disadvantaged. But whether the strengthening of TB control infrastructure in a given jurisdiction has a positive, neutral, or perhaps even a negative effect on more thoroughgoing social reform is both an empirical question and an ethical challenge we must confront in light of the profound inequities that characterize global public health. So I'll conclude with a shameless bit of self-promotion. If you'd like to read more about this, my publisher would be very happy if you bought my book. So thank you very much for your attention, and I'll be happy to hear your questions and comments. Is it just me, or is it really hot in here?
All right. Well, why don't I pose the first question?
Okay.
Yeah. So you said that this, at the end, that this question of whether a very effective and very, focused public health intervention like the one that New York City undertook with regards to tuberculosis, whether that actually makes it less likely than that a city and a community will address the underlying causes of a condition like tuberculosis is an empirical question. So what kind of empirical research do you think might help us, might help some of these students, for instance, begin to address that, that question?
Yeah. I mean, I think it's a really important question to the extent that it asks us to think about what public health as an enterprise does in society. My colleague up at the School of Public Health, Connie Nathanson, who's a sociologist, has a great line that she likes to quote that says, "Public health was designed to forestall revolutions, not to foment them." And the idea is that by making conditions tolerable for people at the bottom of the social ladder and ensuring that diseases that might affect them don't spread to the more well-to-do, that buttresses the existing social order. And so one place to look for empirical research would certainly be during the sanitary revolution of the 19th century, when major urban centers in Europe and the US started undertaking public health reforms that were broad-based in nature and were looking at things like changes in employment conditions and in housing and other basic material conditions of people's lives, and then compare that to later public health reform efforts at other points in the 20th century that were more technical, or to their critics technocratic in nature, that involved things that didn't address these underlying conditions.
Okay, great. Thank you, James. All right, so the first question from the audience.
Hi, thank you, first of all.
Oh, this is nice. You have like a little stand for your questions. You guys could just remain seated, I think, if you want. Hi.
Okay, sorry. So in this map that you showed earlier in the presentation, you noted this correlation between, so I guess you'll bring it up, but correlation between, I guess, poverty-stricken areas or just impoverished areas and cases of TB, but just statistically, like if, for example, if you look at some of the whitened areas, there are still cases there. So statistically, it seems probable that there might be a couple of cases of TB, possibly of MDR, XDR qualities that still remain dormant in certain people in those areas, in those whited out areas. So first of all, would you agree with this assessment that some XDR-TB or MDR-TB still might exist today?
Well, the black dots are symptomatic cases. These are active cases of TB. So these would not record latent or asymptomatic cases.
Right, but if there are symptomatic cases in a region, then it makes sense there would also be asymptomatic cases there as well, right? Right. So first of all, do you think that possibly an XDR-TB strain might exist in a latent, like one of these whited out regions? And second of all, do you think that today we're prepared to combat the threat if such an XDR-TB strain surfaces?
Well, so for the first part, I mean, it's a good question. I mean, I think what the map shows is the extent to which the conditions may foster the reactivation of latent infection for reasons that we either know or we may not know, having to do with things like depressed, the the depressed nutritional status, poor overall health status. I mean, this map would be the same for many other illnesses, right? I mean, virtually any map you're going to see a similar pattern. I'm sorry, what was the second part of your question?
Like if MDR-TB or some strain that resurfaces today, possibly in widespread areas throughout New York City, do you think the system that's in place is sufficient to combat it successfully?
New York City has a very outstanding Bureau of TB control, and I think they clearly have learned from the example of the early 1990s. Yeah, I mean, I think the structures are in place, the improved surveillance, improved mechanisms for ensuring treatment completion. I do think that the city would be prepared to deal with that. Hi.
Hi, I have two questions. The first one is, can you talk about the rates of TB in New York today compared with the rest of the country, the rest of the world? And my second question is, in the cases of confinement, is there any empirical evidence that I guess the environment of confinement also, for example, the improved nutrition in confinement, contributed to the healing of the patients?
The cases in New York, I believe, are comparable to the cases, the case rate in the U.S. overall. I am not very familiar with the U.S. case rate, but I believe they're roughly on the same level. I mean, TB is much, much more a problem of particularly Southeast Asia and Sub-Saharan Africa. So the highest case rate is in Southeast Asia. The highest number of cases is in Sub-Saharan Africa, and the extent of the problem there completely dwarfs the problem in New York City or anywhere in the U.S. Certainly the care that patients receive is very good quality care, and they're also given a variety of ancillary services, so they have access to substance use treatment, they have counseling, et cetera. There's a whole array of social services that go along with the healthcare. I mean, really, it's the consistent medication that is critical, but certainly in the hospital they're being provided with a lot of things that they wouldn't possibly get if they were living in their ordinary situation. I mean, this is kind of an ironic feature of this, is that we give them this kind of care, and then they're cured, and then they go back to wherever they were before they were diagnosed with TB. Yeah.
Oh, would you mind? I know it's a small room, but we're actually recording this so people could see it
I'm
subsequently.
sorry.
That's okay.
I gave subversive instructions.
Not at all. So, if you don't mind, yeah, go right ahead. Sure.
Okay. Great talk. Thank you. My question is: does immigrant contribute to the TB surge, and especially drug-resistant TB? And is that possible to increase the TB cases in New York? What kind of action on that?
Yeah, I mean, in New York City, the cases among immigrants were not responsible for the majority of cases. I mean, this was very much associated with resident cases, indigenous cases to New York City. I mean, there was concern about, obviously, New York City being a global hub and the movement of the many immigrant communities back and forth to their home communities. But I'd want to look back at the data again, but overall, that was not responsible for a major number of cases.
Thank you. Based on the history that you described of TB in New York City, it seems that legislation was an important tool of leverage as opposed to something that was used very often. And that's probably the case for the history of many public health programs. But today, some of those legislative foundations are being taken down by concerns of government intrusion and privacy, some of which are very legitimate concerns. What do you think?
So can you give an example? What do you have in mind with that?
Okay, for example, there's some legislation in place in the state of Oregon that puts in place some of the automated immunization systems that children can be put into a system automatically, and that the information cannot be used for anything else.
Right.
But now the government is saying, well, you know, I think we will want to use this information for other things. And they're convincing the legislature that that is, in fact, a good thing. I'm not so sure that, that it is, because it's just a matter of trust that goes back to how the system was originally set up. And wondering if you have any thoughts or advice about some of these systems that are really dependent on legislation to continue to operate.
That's a fascinating question. I mean, I know the immunization registry story very well. I think it's interesting that you are suspicious of Oregon's efforts. You know,
Actually, I used to run the immunization registry, so I'm not actually suspicious of government. So,
but you don't think that it's a good idea that they want to expand the uses of some of the data in the registry?
actually, I don't in this case. I think it's a good idea, but I don't think it's a good idea to kind of do something that's against the way a system was originally set up, and to use data for other purposes for which it was not designed.
Yeah,
I think it's a
mean,
good idea, but not a good idea to do it by administrative means.
Yeah, I mean, I guess it would depend on the kind of usage. I mean, there's many things in that question. I'm trying to think of which is the way to respond. I mean, the immunization registry is an interesting case because of the resurgence of anti-vaccinationism in this country and the widespread suspicion that people have. And I thought you were going to bring up the example in Texas, where the Texas immunization registry had to purge thousands and thousands of children's immunization records because of angry demands from parents who don't believe in the safety of immunization. So that's a whole other issue. I mean,
but that's an example of what I'm talking about.
Yeah, I mean, one issue that you raise specifically on this issue of legislation is whether it's better to enact public health policies through legislation or through administrative regulations.
Right.
You know, in theory, legislation provides more transparency and more democracy to the extent that people can give their input into legislation, as opposed to administrative lawmaking where public health officials, you know, rewrite the health code. You know, there are indirect mechanisms of accountability for them through whoever is the executive who appointed them. So I'm not sure which one is better. I mean, through legislation, enacting public health policies through legislation may open the process to a lot of people who don't know very much about public health and may have some very misguided ideas about public health. I mean, a lot of the worst, really pernicious AIDS-related legislation in the 1980s came around from legislators that was entirely motivated by bigotry and hatred of homosexuals and drug users. So that's an example of where legislation may not be such a good thing, even if it increases public, sort of democratic participation. I mean, gosh, that's such an interesting question. I feel like I've lost the thread of your question.
Well, I think you've answered the question. Is that it depends on the situation, and that it appears that sometimes legislation is a good tool, and other times administration is a better tool.
Public health law as a field has really boomed in the last decade or so. It's attracted a lot of interest, and there's increasing recognition, I think, among many health authorities that law and legislation and regulation is an extremely powerful tool for advancing public health, and that kind of flourishing of public health law has brought to people's attention a lot of really interesting issues around how do you write your legislation so that it's not overbroad, how do you make the legislative intent clear, et cetera, et cetera.
Yeah. Thank you very much.
Thank you.
Well, thank you. This was fascinating, and I have a couple questions that are no doubt answered in your new book.
I hope.
One's a technical question about other things such as negative pressure rooms, which I think were used first up here at St. Luke's, as I recall.
I don't know if it was first, but they were used,
and then also, it seems to me I wrote something about a new test that came out of the American Society of Microbiology first, or maybe ICAC, and then was used to, very early to test those folks who were being arraigned before they went into the prison system.
So the first question.
And I have a third one.
Oh, and okay.
And that's something of my ignorance.
Okay.
What, up until the time of protease inhibitors, let's say, really when they began to be used widely, let's say 96 or 97, how many of the HIV folks also had TB here in New York City, not in Africa? I don't know. I have no idea.
Okay, so the first question about negative pressure rooms, that actually, I do have something on that in the book, and it's a very interesting story. So one of the real problems, which I didn't talk so much about, was that hospitals were just doing an abysmal job of managing their TB cases. They were, the doctors were not treating it well, and the sort of administrative procedures were just sloppy, and so positive chest x-rays would fail to be placed in patients' charts, medication orders wouldn't get transmitted properly, and one of the things that you have to do when you isolate TB patients is ensure that the room is at negative air pressure to the outside hallways so that the disease doesn't spread. And so hospitals had an enormous kind of hill to climb in bringing their care up to standard, and a lot of the hospitals would spend a fortune on these negative air pressure rooms, but then would not put bathrooms in the room so that patients with TB were in a negative air pressure room, and then they would go walking down the hallway past how many other rooms so they could use a shared bathroom. So the issue of getting hospitals up to code, that was one of the most time-consuming and laborious things that Tom Fried and his team did, because it could be very difficult to exert leverage over the staffs of all of. I mean, there are so many hospitals in the city. Your second question was about the test. I do not know about this test, so I'll defer to maybe if we have a physician in the audience, Steve, or anyone who knows.
I don't know. It depends on which period. Right now they're using quantiferon pill and CGMAs for molecular tests. Earlier they obviously had a lot of tests which were less sensitive.
Yeah.
The city actually, the Department of Health has some data which I think they're actually in the process of analyzing.
No, I thought something was given some test was given within arraignment in maybe 92, 93, 91, something like that. Okay, well, I can look back and what I have. I mean, I have no idea how sensitive and specific it was. It was just a kind of idea of doing a preliminary isolation before they went into the arraignment in Rikers or whatever.
Mm-hmm. Yeah, I don't know. And then your third question, so the number of HIV positive people with TB of HIV would not be known because HIV wasn't reportable, and so nobody really knew how many people with HIV were in the city. In terms of
there were CDC estimates.
Right, yeah, I mean, in terms of diagnosed cases of AIDS, I would actually have to go back and look at my files. I don't have that number in my head. It's a really interesting question, which I don't know the answer in my head. Yeah.
First of all, thank you. And I wanted to ask, you talked a lot in our previous discussion and then also in your lecture about the differences of public health agencies dealing with the social or environmental factors of disease versus the more medical, technical, or curative factors of disease. And obviously, ideally, there would be a very good balance between the two in terms of funding and resources, but public health agencies only have a limited amount of funds. So I was wondering what your personal opinion was in terms of, what the percentage of allocation should be, not exactly, but, generally towards preventative and environmental measures as opposed to curative measures.
Well, I mean, I think your question gets at an important point to underscore, which is that public health professionals politically are not powerful actors at all compared to the various interest groups in society who are fighting for a piece of the budget. I mean, public health as a field is not at all powerful, and so you know, the question of their never mind their mandate, their ability to affect these various societal conditions that they might want to, I think is really in question. I mean, it's the question of allocation of healthcare dollars on prevention versus cure is a very complicated one. I'm not sure I say again your question.
Well, I was wondering what, I mean, obviously there's a range of possibilities, but what your personal opinion was on how much public health agencies should embrace the attempt to affect social and environmental conditions, as well as allocating for treatment.
Well, there are a wide range of things that might be done to affect social conditions that have to do with basic features of a capitalist society that I think are well beyond the ability of public health professionals. I mean, I'm in a school of public health, so my feeling is that public health should always get more money, but of course that's, that's special pleading. I mean, if you look at the overall healthcare budget, a tiny fraction of health dollars in the U.S. is spent on prevention. I mean, regardless of how you define prevention, very little of the money goes towards prevention, and most of it goes towards curative medicine. So any kind of change in that balance, I think, would be a change in the right direction.
All right, thank you.
Hello again. So just building on my earlier question about readiness. So in this particular TB outbreak or series of outbreaks, DOT worked as an effective measure for countering the spread of the virus. But so we hear all the time about the spread of these new novel lethal pathogens, like ranging from E. coli 0157H7 to the flu, all of which make the host body weaker. And you did mention that TB attacks when the host body or the immune system is weakened. So in the case that there was a citywide appearance of one of these pathogens, again, it could be bacterial or viral in origin, would you say that, that the amount of TB, first of all, do you think that an enormous amount of TB cases would result? And second of all, do you think that the city would be able to deal with this massive influx, given the fact that DOT does require, I guess, a significant amount of personnel and also resources to carry out effectively? So
you're talking about the appearance of a new microorganism that increased the incidence of TB?
Or any pathogen that would weaken the immune system and allow dormant TB, for example, to become symptomatic, and then that symptomatic TB would in turn result in increased transmission to people who are already weakened by the initial bacteria, and you could just have this enormous spread.
Yeah,
so,
I mean, you can always imagine sort of doomsday scenarios. I mean, I think it would depend on the nature of what the pathogen was, on the extent of it, yeah, I mean, I think the city has a very good TB control infrastructure, and the systems around the city in terms of reporting is much better than it used to be. The relationship between the health department in terms of reporting of healthcare facilities, of conditions, is much better than it used to be. It could be a lot better, but it's much better than it used to be. So I think the city would probably be well positioned, but you know, in some kind of dire science fiction scenario, who knows?
Okay, so why don't we make these the two last questions? So over to you, Helen.
Yeah. Just there were just back to the question of magic bullets versus social and economic change. Weren't there some other things going on, like finding housing for people with HIV and trying to improve conditions in some of those, I don't know if there was, in some of those homeless shelters and so on, that might also have had some impact, perhaps not as much as DOT, but...
yeah, that's an important point. I'm glad you bring that up. So one of the things that the city tried to do was to provide separate housing for homeless, HIV-positive people and homeless people with AIDS, because they were particularly vulnerable to transmission in shelters, and there were actually many lawsuits against the city by Housing Works and other AIDS service organizations, and so the city did do that, and Frieden and his team, when they talked about the measures that had been effective, mentioned that as one of the things that probably had an effect. It's, you know, when multiple things are happening at the same time, it's sometimes difficult to tease out the effects. But given the significance of transmission in shelters among HIV-positive people, it is almost certainly the case that providing separate, segregated housing for HIV-positive people and for people with AIDS had an effect on it. I mean, it really, I have to concede sort of the limitations of the analytic categories that I'm using, because do you call that a targeted intervention? Do you call that, or does that rise to the level of sort of a broad-based social reform, the fact that you're providing housing for people with HIV? I'm not sure.
Was that the only, I mean, what are those shelters that you showed the picture of? What are they like now? Are they the same? So crowded and squalid?
Yeah, I mean, this is interesting. So the Fort Armory shelter is now the Nike Track and Field Hall of Fame, and there are now track meets where there used to be thousands and thousands of cots. There is still a homeless shelter in that facility, but it's only a fraction of the size. A couple of months ago, the Coalition for the Homeless, which has been very harshly critical of Bloomberg's policies, issued a press release saying that the number of people in the city's homeless shelters is at an all-time high. And I actually do not follow that closely, have not followed closely the recent, the Bloomberg policies on homelessness. So the worst of the shelters were the barracks-style shelters were closed, and people were moved to different kinds of housing. So the picture that I showed, that is not the standard anymore.
You know, by the way, there were track meets then too. I used to run around that track. A lot of people did. It was one of the only places you could hold indoor track meets for high schoolers in the mid-1980s. And so, you know, you were running around those beds. So, yeah, I think that may be one reason, you know, why, well, anyway, we could talk about this, but it was one of those rare instances where, like, kind of middle-class kids, you know, would have encountered kind of homelessness and the public health problems associated with that in a way that, you know, kind of made it visible. But
yeah, I mean, the other thing is that at this time, in the late 80s and 90s, homeless was much, much more visible than it is now. I mean, it was really just, I mean, were people living in New York City at that time? I mean, it was extremely in your face all over. And I think it is less so. Whether that means that the homeless policies are better or not, I don't know.
Hi, thank you for your talk. You mentioned before that the urban nature of, you know, New York City compounded the problems that, you know, the so-called decline of TB caused, and how eventually TB came to have a resurgence in New York City. What do you think, what is your opinion on the efficacy of DOT in more rural settings? Mm-hmm.
Well, DOT has been used in all kinds of settings all over the world, and the data are pretty consistent. I mean, when Tom Frieden went to India, everybody said, you can never do this in India. It's just like, it would be completely ridiculous with such a different kind of social geography and landscape. And he has the data to prove it. So it's been used. I mean, it doesn't really... It is adaptable to different kinds of social landscapes. I mean, it's a model. I think that's one of the reasons it's successful, is that it's a model that can be made to work, provided that you have the adequately trained outreach worker and the pills. I mean, one of the big problems is just that many of these areas just don't have access to the drugs. But if you have the outreach worker and you have the pill, that's kind of all you need. I mean, and you know, a car to get there, or to get to where you have to be able to get to where the patients are.
Well, I want to thank James Colgrove. He's just completed a marathon 4.5-hour session of seminar discussions with 2 different classes, and now a public lecture and a Q&A session. And so I think he's gone above and beyond. Thank you.